Slides up. Good morning, everybody. It was great to hear Alicia's talk. You are such an excellent communicator, and you're so inspiring. You know, when you think about what one person can do to make a difference, I think that you really embody that spirit. So kudos to you. Let me see if I can find my talk here. Try that one. Am I up? Does that work?
The presentation is not up yet.
Okay. What is up? I thought I shared the screen.
It's has started sharing, but this presentation is not there.
Oh, that's weird. Hang on.
Okay.
I also want to thank you for the new share. Let's try that. It should be this one.
There it is. Yep.
Okay. Awesome.
You got it.
Thank you for the shout out for UT Southwestern, but I am sorry to say that Dr. Bay is leaving UT Southwestern. He's starting his own practice, solo practice up in Frisco, Texas. And so anybody who's interested in seeing Dr. Bay, that's where he's going to be. And I think he will be opening his own shop in August. All right, so let's get going here. Happy Education Day. It's a beautiful day in Dallas. I took a walk this morning, wore all of my miles for migraine purple garb. So hopefully I'm psyched and ready to go here. The only thing I can't see is my own slides. It's kind of weird.
Oh, you can't see them?
I can't advance my slides.
Oh, you can't advance them?
No, this is weird. Hang on.
Okay.
Usually I do this from work. Now I'm at home and I don't know what's going on. All right, let's get rid of that. Let's get rid of this.
No problem.
Helen,
did you send them to Helen?
It's okay, I'll get it.
Okay, let me know.
Okay, yeah, if you can't, we have them.
No, but I changed them. So
oh.
I want to use mine.
There you go.
Oh, did I just do that? Okay.
Yep.
All right, awesome. So a lot of the therapies that I'm going to talk about were actually kind of new a year ago. So there will be a little bit of repetition, but there are some things that are really brand new and up and coming. And, we've had a lot of experience with some of these things since the last time we met. For my disclosures, I have consulted with numerous pharmaceutical companies and have gotten grant support from several as well, and I will be talking about some of their products. Okay, so what I would like to do today is kind of talk about new and emerging treatments, not just medications actually, but also devices, which you've heard about some of them from Alicia, and both acute and preventive treatments for migraine as well as cluster headaches. Compare them to some of the older medications that we've been using for a while, and talk about, when we should use them and what their indications are. So this is kind of the menu. We'll talk about the monoclonal antibodies, the small molecules that target Cgrp, the ditans, which were new and I think not even on the market when we met last year. Emerging therapies targeting a different molecule, PACAP, which is in a way kind of similar to Cgrp. The devices and reformulations. So, from the point of view of someone who takes care of patients who have migraine, I strongly believe that anybody that you go see, a neurologist, your primary care, or a headache specialist, the first thing that they should be talking to you about is how to abort your attacks. And that can include medications, but it can also include a lot of other things that are not pharmacological, such as rest or biofeedback. Sometimes caffeine is helpful. Some people like to use heat, some people like to use cold, and then medications and devices. And there are a lot of things that we use for acute treatment. And some of them are available over the counter. Some of them are prescription drugs. I think it's important, and it always surprises me how often my patients are not taking drugs or medications or other treatments for their nausea. And nausea is usually such a big part of migraine. Oh, what happened? Uh-oh, go back. There we go. Nausea is such a big part for many people, and for some people, the nausea is almost worse than the headache. So it's important to address that as well. So lots of different options. We're going to talk about some of them. We really try not to use opioids. And I understand that there are some people that can't use some of the other treatments because of various medical conditions or because of drug interactions with medications that they already take. But in general, this is not a first-line option. And we try to avoid them whenever possible because they can not only lead to being dependent on them, but also they can sometimes make your headaches worse if you end up taking them too often. So there are two different strategies for acute treatment. One's called stepped care and one's called stratified care. And many people find that they can sort of incorporate both of these things depending on what kind of headache they happen to be having that day. And for some people, not all their headaches are different. So if you can tell early on whether you think this is going to be a bad headache or not so bad headache, sometimes people can use stepped and stratified care. So stepped care is kind of what the insurance companies like, because stepped care starts out with medications that are generally inexpensive and medications they don't have to pay for. So example, sitting at work, back when we used to go to work, right? And getting a migraine, kind of feeling that tension coming on and know it's going to happen, and pop a few of acetaminophen, right? 45 minutes later, the migraine is still escalating. The acetaminophen really hasn't done much yet, so let's go to ibuprofen. And now if another 45 minutes go by and, start rummaging through the desk, what do I have? And, maybe take some butalbital, which we don't really like that drug either in headache medicine, but sometimes it works. Now, it's been like, how many minutes have gone by? Over 2 hours. And so we'll take the triptan. Well, why didn't we take the triptan to begin with? Well, because I only get 9 in a month, right? And so I got to really ration them. And maybe this isn't going to be the worst migraine of the month, and maybe I'm going to need it later, so I'm just not going to take it early. And the problem is when that pattern happens and hours go by before you manage to find a treatment that should be effective, the changes in the brain that occur with migraine have already occurred. It's called central sensitization. And what happens in central sensitization is that the connections from the trigeminal nerve, which supply the sensation from the face and from the lining around the brain, which is called the dura, they feed into the brain, into what's called the trigeminal vascular system, and they start kind of revving up the system. And so what happens is that it becomes easier and easier to develop bad pain under certain circumstances and harder to turn it off. So this kind of cycle tends to bring incomplete relief. The other side of the spectrum, if you will, is to use stratified care. And that's to just start with the treatment that's most likely to work for either a particular individual or even a particular headache, okay? And the goal is to treat early within the first hour, preferably before central sensitization begins. And I kind of I liken that to go for the gold, okay? Hit it hard and try to treat early before things totally get out of whack. And there's clearly a balance to this. Every time you feel a twinge, you can't be using, your triptan or your ditan or your Cgrp drug or whatever it is, because some of these drugs can cause medication overuse headache, and that's going to make you worse in the long term. So there does have to be a balance. So let's move on to Cgrp, or calcitonin gene-related peptide. I think, as most of you are probably aware by now, this is like the hottest and greatest thing to happen in the migraine landscape in 25 years. This is a peptide, and it is it dilates blood vessels. It's normally made in the body. It's found all over the body, And so one of its actions is it dilates blood vessels. It also mediates what we call neurogenic inflammation, which is part of migraine. And we find CGRP in that trigeminal system. So hopefully you can see the pointer. There's the trigeminal nerve up there that is supplying the lining around the brain. And it kind of feeds into what's called the trigeminal ganglion, where the three divisions of the trigeminal nerve that supply the face sensation come together. And then that information is then transmitted into the brain itself, which is part of the trigeminal vascular system. So CGRP has a lot of different functions besides dilating blood vessels. It blocks the inflammation that occurs at the level of the blood vessels that supply the lining of the brain. When migraine starts, they release different chemicals that sort of set up just a storm of inflammation. And so it's released during migraine and cluster headache. And it's also present on these nerve endings, and the levels of CGRP are elevated in the bloodstream during migraine and cluster headache. So for those of you who are saying this woman is speaking Greek, let's talk about Greek. What's a peptide? A peptide actually comes from a Greek word, peptos, which means digested, which kind of makes sense. Think about Pepto, right? Pepto-Bismol, which helps digestion. And it is a compound that consists of amino acids. So if you remember back from high school biology, amino acids are sort of the building blocks of peptides, and peptides are the building blocks of proteins. So when you eat proteins, they're actually broken down into amino acids, and they're composed of different elements, if you will, and then some of them are used to form neurotransmitters. So we now have on the market, which we didn't have, I think, a year ago, or at least they were maybe just released about a year ago, acute treatments that target CGRP. And so there are two of them that are currently on the market. One is Zavejapant, which is marketed as Nurtec. The other one is Zavejapant, which is marketed as Ubrelvy. And whoever thought of that name, I don't know what they were doing. I know that the company actually has very little to do with the names now. There's this whole world federation that comes up with drug names. But I find that 75% of my patients cannot pronounce Ubrelvy correctly. So they might be regretting that decision, I don't know. There is another acute treatment that's in development. It's called Zavejapant. So these things all end in Gprant, like triptans all end in triptan. And this is going to be an intranasal medication. It's currently in phase 3 clinical trials, which is kind of the last phase you do before the FDA will approve it. Zavejapant also has the option to be formulated in other ways besides intranasal. So that will probably be coming down the pike. The other new category that was released in the past year is the 5-HT1F receptor antagonist. 5-HT is serotonin. Serotonin, became well known in the migraine world over 25 years ago when Imitrex or sumatriptan was released on the market. And sumatriptan was probably the second designer drug made for migraine in the history of migraine. And so sumatriptan was developed back when we thought that migraine was a vascular process, right? So the old theory was that, migraine started with constriction of blood vessels, which caused aura, and then you got dilation of blood vessels, which caused headache. We know that's not really true anymore, although there is a vascular component to migraine. So the triptans were designed to target the serotonin receptors that cause constriction and dilation of blood vessels. The problem is that the 1B receptor, which is one of the ones that the triptans target, causes constriction of blood vessels. And that's probably responsible for many of the side effects that people get with triptans. and like the chest pain, for example. And it also limits the use of triptans because people who have heart disease or uncontrolled high blood pressure or Raynaud's phenomenon are not supposed to use triptans. So the 5-HT1F receptor also lives at that nerve terminal where the 5-HT1B receptor lives. And it's different because it has no effect on blood vessels. The drug itself does enter the brain. So there are some side effects that can occur from that, as well as some good effects that can occur from that, because it works inside the brain. And it also blocks inflammation in the dura. So the only medication thus far that's available for blocking 5-HT1F is lasmiditan, which is marketed as Rayvow. And when they did the clinical trials of Rayvow, they included some patients who had vascular risk factors. They found that with the 200 milligram dose, which is not what eventually was marketed, it's a 100 milligram dose. There's also a 50 milligram dose. But the 2-hour pain-free rate for migraine was close to 40%, which is twice as good as people that received the placebo treatment. And when they looked at 2 hours of pain relief or relief of the most bothersome symptom, that was only almost 50% of people. Dizziness, apropos to the previous talk, was the most common side effect, and that's because it gets into the brain. But there were no significant cardiovascular side effects, which is important. And patients who had these cardiovascular risk factors did not seem to have any particular problems with it. Now, Eli Lilly, who developed and made Rayvow, they were required by a new mandate from the Food and Drug Administration to do driving simulation tests because the drug enters the brain, which no other medication for migraine had ever gone through before. So, take this with a grain of salt. So they took healthy volunteers, they gave them lasmiditan, they put them in the driving simulator, and they found that up to 8 hours later, they were still like some people that were not quite driving within the lines. And for that reason, the warning and the recommendation from the FDA, and the reason it's considered a Schedule 5 drug is because you cannot drive for 8 hours after the administration. And some of these people and again, these were not people with migraine that did the trial, but some of these people were really kind of unaware of the fact that they were not driving inside the lines. Let's move on to preventive treatment. We recommend preventive treatment in patients who have had at least 4 migraine attacks per month or at least 8 migraine days per month. But, that 4 migraine attacks that render you completely disabled, that is not the only criteria, right? So you can have fewer attacks per month, but if they have a really negative impact on your quality of life and ability to function, that can still be a consideration for using preventive treatment. The other criteria include patient preference. If there is unacceptable migraine-related disability, despite managing triggers and appropriate use of acute medications and lifestyle modification. If there has been treatment failure in the past to acute medications or medical reasons why acute medications can't be used, overuse of medications that are taken for symptomatic treatment, or intolerable side effects, we're going to start thinking about preventive treatment. Migraine with brainstem aura, and vestibular migraine sort of fits in that category. Before it was made a separate disorder, and there are things about it that are certainly different from typical migraine with aura, but it used to be part of migraine with brainstem aura. So I think that it, would qualify as well. Or hemiplegic migraine, which is migraine associated with weakness. And then also for the short-term prevention for predictable menstrual migraine with prolonged aura, or somebody's had a history of a stroke related to a migraine. So until recently, this is kind of what we had. We had medications that were made for other conditions, that we found, some mostly just by accident, but that's okay. They're found to work well for migraine. So the antidepressants, the mood stabilizers, medications for blood pressure, medications that were initially marketed for seizures, natural medications, nutraceuticals, and then came along onabotulinum toxin A, or Botox, for chronic migraine, neuromodulation, which we'll talk about a little bit, and then the anti-CGRP monoclonal antibodies. And we know that there are problems with these medicines, even though a lot of people do very well with them. If you look at the rate of people that continue to fill their prescriptions and continue to take them over time, they're not very good. So just using claims data from large insurance plans, we know that the annual discontinuation rate of oral preventives is at least 40%, and it may be even much, much more than that. The most common reasons are that it either didn't work, or there were side effects, or unfortunately, only in a small percentage of people, their headaches got better. So there are some strategies that can be used for improvement, and that I think requires good communication with whoever is managing your migraines, patient education, knowing what to expect, what the common side effects are, what to worry about and what not to worry about, what goes away over time and what doesn't. And then sometimes cognitive behavioral therapy added to the treatment will help. But certainly, when we had only oral preventives, we needed better treatments. So we got finally the monoclonal antibodies against CGRP. And they block CGRP, but they don't seem to cause any significant constriction of the blood vessels. Remember, we need CGRP to dilate blood vessels. And there's certain situations where we want CGRP to dilate blood vessels. For example, if somebody's having a heart attack, right? We would want as much blood flow to the heart as possible. The monoclonal antibodies work outside the brain. They're very large molecules. They can't really get into the brain. And they reduce the amount of CGRP that's available without, we used to think without affecting other targets. They may affect other targets. And I think that's why people experience some of the side effects that were not really obvious in the clinical trials. The good news is they're not eliminated through the liver, and they're not eliminated through the kidney. So if people have liver problems or kidney problems, they're a very good option. They're eliminated through a different system that's called the reticuloendothelial system that gets rid of antibodies. So here they are, and in no particular order. So galcanizumab is Emgality. It is given by injection once a month. You can use it it's been studied actually in episodic and chronic migraine. And it's also been studied in cluster headache. So there were 2 of the antibodies that were studied in cluster headache. And the Teva study, which was frebenizumab, was abandoned because they did an interim data analysis and didn't think that the trial was going to be successful. But galcanizumab went through with the trial. They studied it in episodic and chronic cluster, and it is FDA approved for the treatment of the prevention of episodic cluster headache. The trial was negative officially for chronic cluster headache. And next is eptinizumab. So that's the one that's really kind of come out on the market over the past year. And we're starting to get more experience with it. It's called Vyepti. So it's different. It's administered intravenously every 3 months. It was not studied for cluster headache, but it's like all of the others, FDA approved for migraine, episodic or chronic migraine. Arenumab was the first one that came out. It's Aimovig. It's different from the others because it blocks the receptor that the CGRP binds to. The other 3 bind to the CGRP itself. So when the drug or the molecule binds to the CGRP, it binds to a very specific spot on the molecule. It changes the shape of the molecule because now there's something else hooked onto it. When the molecule floats over to the receptor, which also has a very specific shape, it's like a lock and a key. When the molecule binds over to the receptor, it can't get in, right? Because the key won't fit in the lock. And Arenumab is the other way around. It binds to the receptor. So when the molecule floats over and tries to bind, which is how it works, it can't get in the door because something else is taking its place. And then Fremanizumab is a Jovi, and that is different because it can be given either every month or triple the dose and give it every 3 months. They were all studied in migraine, both episodic migraine, high frequency episodic migraine, chronic migraine. They sometimes have a very rapid onset of action. I suspect many of you out there have tried at least one of them. So for some people, it's like a miracle occurred and their migraines just go away. For other people, it takes longer. And so we usually recommend up to a 6-month trial because sometimes it can take that long before people start to respond. And that sounds like a long time, but when you think about Botox, it's the same thing. They all were superior to placebo in reducing headache days. They all reduced the amount of acute medication use and the average improvement over placebo. So keep in mind, this is not the average improvement overall, because people who use placebo get better too. The average improvement over placebo was 1 to 2 migraine days per month for episodic migraine and 3 to 4 at least days per month for chronic migraine. They all seem to be pretty well tolerated for most people. They can be effective when other things have never worked before. And so far, there's only one contraindication. So we don't know about pregnancy, and we recommend that women who are considering getting pregnant come off the medications at least 5 months before starting that process of conception. And there is now a black box warning on Aimovig or Arenumab that people who have uncontrolled hypertension, you need to be really careful. And it can also cause, very rarely, but it has caused very high blood pressure, even in people who did not have very high blood pressure to start with. So it's just something to watch out for. It's not really it doesn't really preclude you using the medication, but you have to really keep an eye on the blood pressure if you're taking Aimovig. The most common side effects were injection site pain, redness, constipation, especially, again, Aimovig. In some people, it just totally locked them up. They had to have surgery because they were so constipated. Again, it's rare, but something to think about if you have baseline constipation. Other things that were seen were sort of flu-like reactions, nausea, urinary tract infection, and there were some reports of abdominal pain, back pain, and hair loss. I think we've seen more patients who have had trouble with hair loss since it came on the market. But so far, no definite signal of a cardiovascular adverse event. These are just data from the clinical trials showing the active drug, which is the bottom two lines over here, the blue and the orange. This is for Arenumab or Aimovig compared to placebo. And what we're looking at is the decrease in the number of migraine days. And so you can see that by the 4th week, there's definitely a difference between the active treatment and the placebo, which persists through month 3, which is when the clinical trial ended. We also know that these medications can be effective in patients who have had prior treatment failure. And all of the monoclonal antibodies ran similar studies. These are the data from Arenumab. And so the people in this trial have had to have taken at least 3 first-line preventive medications in different categories, and they either had no benefit or they didn't tolerate them. And it turns out that almost 75% had received previous preventive treatment. And even in this group, which we would consider being pretty difficult to treat because they had already tried things before that didn't work, This time the placebo is in black, but you can see that in all of these groups, no prior treatment failure, at least one prior treatment failure, and at least two prior treatment failures on the bottom, that the active medication was far superior than to the placebo. This comes from the Eptinezumab, which is the intravenous medication. This is from their pivotal trials. And the first graph that's over here on the left is their primary outcome, which is the decrease in number of migraine days. And you can see that they did better than placebo. Although again, intravenous placebo seems to work pretty well in and of itself. The more invasive the treatment, the better it works, even if it's placebo. Looking at the 75% responder rate, so people who had at least a 75% reduction in their number of migraine days. This time, I think it's much more striking that even early on, in the first 4 weeks after the infusion, you can see that between 30 and 40% of people had at least a 75% response compared to those who got placebo. And this one, I'll take you down to the bottom, shows results as early as day 1 after receiving the infusion. Now, does this happen to everybody who gets Eptinezumab? No, but there are people that were in the study who had a result as early as day 1 that was persistent throughout the duration of the trial. So it gets in the system quickly, and for some people, it works very quickly. Some comparison to current treatments. These are from the Botox clinical trials. And as you can see, the graphs kind of look really similar to what we just saw, right? So within 4 weeks, there's a pretty marked decrease in the slope. This time the placebo is in gray and the active Botox is in blue. And as time goes on, for the first 12 weeks, which is when the monoclonal antibodies had their primary outcome, there's still a significant difference in the number of headache days in the Botox, the people who received Botox compared to those who received placebo. And the numbers of mean reduction of headaches is actually pretty similar. These are the data from the topiramate clinical trials. So topiramate did very well in clinical trials as well. And over here on the right, you can see the placebo is in black, the topiramate is in gray, looking at the reduction in the number of headaches at 12 weeks, between 4 and 6, compared to nothing for the placebo tablets. So, at the end of 16 weeks, end of 4 months, it was even better. And that was their primary endpoint. The problem with topiramate, even though it's very effective, which was marketed as Topamax, is that the side effects for many people are intolerable. They were the only oral drug that ever looked at 75 and 100% responders. They also found a pretty high 50%, 75%, and 100% responder rate, very similar to the monoclonal antibodies. The problem is that a lot of people dropped out of their studies because they couldn't tolerate the drug. So you have to kind of keep that in mind when you look at their data. So in general, I think, there are some pros and cons to using monoclonal antibodies versus the oral. The monoclonal antibodies, it's more of a commitment. Once you inject it, it's in your body for a month if you're using the self-injection, or it's in your body for 3 months, at least, actually in there longer. And you can't take it out, right? So that's a little different from oral medicines, that you can just stop the drug anytime. But the good point, I think, is that you don't have to titrate the drug. You start at the maximum dose. For some people, they have a very rapid onset of action. Some people are considered super responders, but not everybody. There's a relatively low incidence of side effects compared to the oral drugs. Again, they don't go through the liver or the kidney. So if you don't have to take something every single day, chances are you're going to stick to the regimen better. You can take it for any kind of migraine, episodic or chronic. But the downside, and this is where we need your help, is the high cost and the insurance coverage. And I, suspect that you have been on the receiving end of this as well. It is a major, major hassle to get these medications for our patients. I never dreamed in my entire life that somebody sitting behind a desk at an insurance company would be the one who decides what medications my patients should get. And so, it depends on what's on their coverage, covered on their plan, how many meds you tried first, how many things we can prove to them that didn't work or weren't tolerated. It's a nightmare. And I know it's a nightmare for you too. So this whole pre-authorization thing and the limitations, and then it expires, and it's just horrible. So most of the orals, we don't have that problem because many of them are generic, they're covered by insurance, and most of them we don't have to pre-authorize. But they have their downsides as well. So they do go through the liver, they do go through the kidneys. We have to watch that in some of those medicines. They have probably more side effects, or at least the potential for more side effects. And you do have to ramp up the dose for most of the oral medications. Compared to Botox, Botox is once every 3 months. It's very similar to Eptinezumab. The downside of Botox, first of all, is it's only chronic migraine. The company that makes it is planning to do another study in episodic migraine. They studied it a long time ago, and they didn't show superiority to placebo. So we'll see what happens. I think Botox is a super good option for patients who have a lot of medical problems, because it's not really systemically absorbed. It doesn't interact with anything. It's very safe. We have over, many, many years of experience with it, not just for migraine, but for other conditions. But sometimes you do have to try it 2 or 3 times before you can really assess whether it's effective. It does require pre-auth, but it's been around for a longer period of time, so it tends to be covered on most insurance plans. The problem is when you want to start mixing it or combining with a monoclonal antibody, then that's where the real battle begins. And it is an office procedure. Moving on to the small molecules, we kind of mentioned them really briefly in the beginning, but some of the small molecules not only will be used for acute treatment, but they're being studied and submitted to the FDA for prevention. So Zavejapant, which doesn't have a name yet, but it has been submitted to the FDA. Zavejapant, which is Nurtec, they did a trial using Zavejapant every other day for prevention. It did very well. It's at the FDA right now being evaluated. And then Zavejapant, they changed the name of the drug in the past year. Zavejapant is also in clinical trials for prevention. So before we leave CGRP, I really just want to give a huge shout out to some of my colleagues who won a huge prize. The Lundbeck Foundation Prize in Neuroscience for 2021 was awarded to Drs. Peter Goadsby and Lars Edvidsson. Peter Goadsby is currently the president of the American Headache Society. He's been the president of the International Headache Society. They started working on CGRP back in the 1990s or late 1980s, actually. And so it's because of their work that we now have these treatments. And kudos to them, because, this is what part of their life's work, and it's been recognized by Lundbeck Foundation. They also are sharing the prize with 2 other giants in headache medicine science. One of them is Dr. Michael Moskowitz, who did a lot of the early work in serotonin and the mechanism of migraine at Harvard, and Dr. Jes Olesen, who not only has done a lot of clinical work in migraine, but is sort of the founder and the godfather, if you will, of the classification system that we use for headache. Another possible target is PACAP, and I know that I'm probably running over time, so I'm not going to say much other than it acts very similar to CGRP. It's also a peptide, and it's currently in clinical trials. And I know that Alicia talked about neuromodulation, so here's what we have. She mentioned the gamma core. Dr. Bay actually did a study with the gamma core for vestibular migraine. It was published and showed benefit in patients who had vestibular migraine. It stimulates the vagus nerve that's right over here in the neck. It is kind of a funny sensation, and it gives you a little lip pull when you use it, but otherwise very well tolerated. It's useful for migraine as well as cluster headache. Transcranial magnetic stimulation is kind of faded out over here because it's currently not available. The company went out of business that originally made it, but another company, I've been told, has purchased it, and hopefully it will be back soon and available to you. The Cephali device, it's a trigeminal nerve stimulator. It sits over here on the forehead. It stimulates the trigeminal nerves as they are arising actually from the eye area and traveling up through the forehead, and or actually the other way around, and taking the information into the brain. So it can be purchased online. You do not need a prescription anymore, and it is approved or cleared by the FDA for both the acute and the preventive treatment of migraine. The new kid on the block is the remote non-painful electrical stimulator, which is called Nerivio. It's a device that's worn on your arm. It's really kind of interesting. It blocks the signals, or it interferes with the signals coming from the brain, the face and the body to the brain, and vice versa. It's controlled by your cell phone. And so you just put it on your arm. It's discreet. You don't have to stick anything on your head. You can hide it under your clothes. Turn it on, and it does its thing. And it's not supposed to be painful. So you set the settings so it's not painful. And then the new one that will be available probably this fall is Relivion, which stimulates in the front, and it also stimulates in the back. So it's the first one that actually is going to stimulate the occipital nerves as well as the trigeminal nerves. And their clinical trial data look very, very good. Currently, I know a lot of these things were really cost prohibitive in the past. The Gammacore device, great device. It was so expensive, like nobody could afford it. And same thing with Cephali. The prices have recently come down. Some of these companies are running a special, if you will. The Nerivio is one of them. Gammacore is one of them. They are available only by prescription, but you might find that you're able to try one now because the cost has come down a little bit. Last section is kind of old dogs, new tricks, things that are being reformulated. So the non-oral triptans, we know that a lot of people cannot take oral triptans because they have a lot of nausea and vomiting during their attacks, or part of the migraine process is that the stomach doesn't work well. Things are supposed to come in your mouth, go to your stomach, go through your bowels, and come out the other end. Well, when people are nauseated, it means that things are working backwards, right? They're trying to come out the front end instead of the back end. And then the stomach's not really pumping things through like it should. So sometimes oral medications don't get absorbed well during migraine. And this might be one of the reasons why your oral medications don't seem to work very well. So the one that came out in the last year is Tosymra, which is a sumatriptan nasal spray that actually gets back into the back of the nasal cavity a little bit better, and certainly doesn't have the bad taste that the original nasal spray has. So that might be a good option. In clinical trials, we have a transdermal microneedle array, which is being studied for the delivery of zolmitriptan, both in migraine as well as in cluster headache. It worked very well for migraine. The device went to the FDA, and they found some kind of disparities between device lots and how much actually was getting into the bloodstream. So that kind of has gone back to get corrected to the company. But other things that I think you'll hopefully see in the future: oral liquid celecoxib, which is Celebrex. Now, DHE, it's been around for a very long time, but there is a new nasal spray. There are actually two new ones that are coming out that really, again, get back into the back part of the nose where they get absorbed well, rather than getting swallowed and they don't work. There's an meloxicam rizatriptan combination in development, as well as, I can't believe how long it took for this to happen, a combination of a triptan and an antiemetic. So we'll see what happens with that. And then there's a new botulinum toxin that hopefully will last longer than onabotulinum toxin. For a lot of people, Botox wears off after about 10 weeks. It's almost uniform. But daxibotulinum toxin may solve that problem. In summary, it's a really exciting time. The past few years have just been an explosion in the field of headache medicine. We now have, for the first time almost ever, preventives that were designed specifically for migraine, things that can be used for acute treatment in patients who have vascular risk factors. It's like everything else. One size does not fit all. What works for one person doesn't always work for another. We still may have to use multiple therapies. And the new options do seem to be better tolerated. We have Gpants now, and uses for other headache conditions will likely follow. So, I think my overall message is to have hope. The field of migraine is evolving very rapidly. There is ongoing research, not only in the medication world, but in the device world and in the natural world and in the mindfulness meditation world. I am really grateful to Miles for Migraine, for your support of our fellowship. I'm grateful for all of you. And my hat, literally my Miles for Migraine hat, is tipped to you all for what you're doing. And what you're doing is so, so important. And as providers and as physicians, we cannot make changes on our own. It has to come from the people who are actually experiencing the problem. And I know that there's been a lot of stigma about migraine, and I'm glad that the migraine community is finally getting organized and trying to make change and going to Headache on the Hill and lobbying and contacting your congressional representatives. But the situation that we have now, as far as getting you the treatment you need, in my opinion, is pretty intolerable. And the only way it's ever going to change is going to be starting from you. So I hope you're on the board and on the bandwagon. I'm happy. I don't know how much time we have, but I'm happy to answer any questions you have. It doesn't have to be about treatment. I know that some came up on the previous talk that I can help you with as well. So fire away.
I agree. Thank you so much. It starts with all of us together talking about our disease and making sure people understand it is a disease, right, Dr. Friedman?
Absolutely. The most common neurological disease on the face of the planet and the most disabling.
Correct. And we all have to talk about it. Thank you so much. Your presentation was wonderful. I have a few quick questions here. Does Nurtec work for vestibular symptoms?
I would imagine that it does. It's never been specifically studied for vestibular migraine, but again, it's been studied for migraine with aura.
Okay.
None of our treatments have ever been studied for aura alone. Okay, and that includes, the difference between vestibular migraine and other vestibular things. I think are that in vestibular migraine, part of the criteria include having attacks not only with headache, but as Alicia mentioned, without headache. And that would be sort of like having aura without headache, which can occur. Nobody's ever studied any treatment in aura without headache. So, I can't answer the question about whether you should take one of these things when you have vestibular systems without headache. It certainly is not going to hurt you, but there's no evidence saying it's going to help either.
Very true. As you said, yeah, as you said, try, right? Does lismidodon interrupt anxiety drug functioning like sumatriptan can?
I don't think it does.
Okay.
I mean, there's nothing in the package insert and nothing that they found in the clinical trials that suggests that should be a problem. I mean, yes, it works at serotonin, but it's only one receptor, and I don't think it's an issue. I have not heard anything about that.
Okay, wonderful. And why do placebos work? Why do placebos actually make you get better or show better, show results?
Well, remember when you were like a little kid? It's a real thing. It's a real thing. It's not just you're making stuff up, right?
Yes.
So like, remember when you were a little kid and you went to your mom and you said, oh, I have a boo-boo. And she said, I'll kiss it and make it better. And sometimes it did, okay?
Yeah.
That's the placebo effect. And the placebo effect is real. It is a brain process that, you know, our body, I guess, has evolved to use because sometimes we need it. But the problem is when we do clinical trials, the gold standard is to compare the active treatment to the placebo treatment.
Right.
So the placebo effect with oral medications for migraine in clinical trials is about 15%. 50% of people, they're taking something.
So mentally,
they're in a clinical trial, and even being in a clinical trial has a placebo effect, right? You're doing something that's important. These people are all following you. You're giving data. Okay, that's a good thing. So, you know, it's just natural. Things tend to get better when you're in a clinical trial.
feel better because I'm helping them. Yeah,
absolutely. So,
okay.
But the more invasive it is, the higher the placebo rate is. So once you start moving to injections, you know, like Botox was an example of this. People got better when they got, believe it or not, saline Botox injections. You would think that you would know if you were getting real Botox because you could wrinkle your forehead or not, right? But people did get better, and a lot of them did not know they were getting the placebo. And then when you take the next step to like injecting it under the skin and in the muscles, and then finally IV, then it just goes higher and higher and higher. So the bar is a little bit higher to go over, if you will, the more invasive the treatment is. But, you know, placebo, honestly, we can use it to our advantage, right?
True.
And I think as providers, we do this every day, sometimes without knowing it. So it's not really a bad thing. It's something about our brain that Mother Nature has given us.
Very true. So one last question we have here. So many preventative medications worsen dizziness. Which is what are the main symptoms of vestibular migraine?
It's kind of funny because the medications that we use to treat headache, when you look at their side effects, headache's usually one of them, right? And the same thing with dizziness. Dizziness is one of them. So vestibular migraine, I don't have the official criteria right in front of me, and I do encourage you to read Dr. Bay's book. That's what he did during COVID. Like, I was cranking out patients, he was home writing a book. I'm like, how'd you do that? So it's migraine that is associated with a vestibular symptom, which could be spinning dizziness. It could be imbalance. It could be that I just feel like I just got off the boat sensation, right? There's not one particular vestibular symptom, but the symptom can be either associated with headache, and I think you have to have migraine at some point to actually get the diagnosis, migraine with headache. But you can also have attacks that occur without headache. And those attacks can last even longer than what we specify for the duration of migraine. So migraine is up to 72 hours. But the attacks of dizziness can actually go on for longer than that. And there's a whole set of approved criteria for the diagnosis of vestibular migraine. I encourage you to look them up. I know somebody had a visual snow question. Do you want to answer that, or are we out of time?
Oh, no, you can go ahead and answer that if you'd like. We're over, but if people are still on,
they can go home and have lunch if they want.
Yeah,
So,
they're listening to you. So if you have a quick answer to that, go ahead.
It's up to you.
No, go ahead.
Okay.
They're on here, so everybody is loving what you're talking about.
Thank you. So visual snow got its name. It had a different name to begin with. It was called persistent positive visual phenomena. It was renamed visual snow because it kind of looks like TV static. The old analog TV, when there was like this black and white and gray TV static when the reception wasn't too good. Maybe some of you too young to even know about that. You could Google it. But anyway, and so that's one of the things that people with visual snow can see. And so there's this kind of static that it doesn't really block vision, but it's sort of always there. And it's super distracting. there are other manifestations of visual snow as well. Some people will see, as they look from one object to another object, they'll see kind of a trail behind what they just looked at, so the objects trail. When they look at the beautiful blue sky, they can sometimes see all this white stuff in the blue sky. What else can they see? Sort of like clear floaters can also be in the vision. There's a whole bunch of different manifestations of visual snow. Now, it doesn't actually come, some of it is actually normal, okay? After images. So looking at something and then looking away and sort of seeing the photographic negative after image. Now, a lot of this stuff is normal, but we don't pay attention to it. And it comes from the brain. And for some reason, somebody has, changed the gain on people who have visual snow. And so they are constantly aware of these sensations, and they are incredibly distracting, and they really interfere with doing a lot of things. For example, taking a test. So you try to take a test and you're seeing all the stuff and you're trying to read the print, and it's a problem. So visual snow, as it turns out, is much more common in people who have migraine. Sorry, it's not migraine, but it is more common in people who have migraine. Similar to migraine, it also seems to get worse with stress and anxiety. And I'll tell you that pretty much every neurologic condition gets worse with stress and anxiety. So don't think that anybody's picking on you when we say that. It's just a natural thing. But it does get worse with anxiety, and it does, similar to migraine, kind of, I think, lead to sort of this vicious cycle, because visual snow is anxiety provoking, right? So which came first, the chicken or the egg? We have, unfortunately, no known effective treatment for visual snow. There are a couple of things related to behavioral therapy that I really would love to study if I had the time to do it, because I think they might work. But, and for most people, it just starts suddenly out of the clear blue sky, which is kind of unusual for most disorders. So that's the visual snow story. It's not coming from your eyes. You're not going to go blind. You don't need to see 25 eye doctors or neuro-ophthalmologists, which is who I tend to see. But it does come from the brain. There have been functional imaging studies showing areas of the back of the brain, which is what's involved with vision and processing of vision, that seem to be related to visual snow.
Well, that's good to know you're not going to go blind.
Not going to go blind.
Or then it doesn't have anything to do with your eyes.
Correct.
So that is a positive from it, but unfortunately, it's your brain too. But thank you so much. It's always wonderful to hear you speak. And you gave me some new perspective on some of the stuff you spoke to in the very beginning, but now, I listened to so much, it's all jumbled together, but I love listening to you speak. I think I could do it weekly. So thank you very much. We popped a quick question on, if you all could answer that, about learning about vestibular migraine, if you would be interested in hearing more, if you want us to put together another education day on it. This is the first time we've spoken about vestibular migraine. So again, as I'm going on about it, it's just a topic that I haven't heard much on, vestibular and cluster. And so I've learned so much today, and excited about our future going forward with migraine. And as Dr. Friedman said, it does start from all of us. So if you guys could, and I didn't see the answers to that, Helen. So so I'm going to thank everyone, thank Dr. Friedman, and please don't forget, Alicia brought it up. Don't forget about our advocacy story project. If you have a story that you would love to share with us and our social media, we would love to hear your story. We will share it on our social media. We also have editors that can help you write your story. So if you aren't comfortable maybe writing your own story, we have editors at Miles for Migraine that can talk to you, that you can help share your story. They can write it for you, with you, and we can help share your story. It starts with all of us, as we've said today. And share